Welcome, my friend, to the show that never ends. Another Puscast covering the last 2 weeks of January in the year 2017. References for this Puscast can be found at edgydot.com, the home of my growing multimedia empire. Otherwise, you're interested in the literature. So let's move on, shall we? It is a nasty flu season. Of course, everyone listening to this podcast has had the flu vaccine, and if you haven't, stop listening. You're not welcome here. Because you don't want to risk giving influenza to your patients. This study looked at the outcomes of patients who developed their influenza in the hospital-acquired flu. And they came up in this Spanish study with 9.3% of cases, and found almost double the mortality rate of patients who developed their influenza, acquired their influenza in the hospital. It was 32.9% versus 18.8% for those who acquired their influenza in the community. And if you had a hematologic malignancy, you were also more likely to die of your influenza. This is not the first study to show increased mortality for hospital-acquired influenza. The Kaplan-Meier survival curves, or as an infectious disease doctor, I think of them as time-kill curves, are quite dramatic, with hospital-acquired influenza dying quite rapidly compared to their community-acquired comparators. But hospital-acquired H1N1 may be the least of our worries. There's currently a ton of avian influenza outbreaks in the world currently. They've had almost 40 outbreaks representing about a half dozen different strains of avian influenza. The worry, of course, is the propensity of influenza to mix and match its genes with other strains to give a whole new strain of influenza, another shift. With all these avian influenzas in the world right now, perhaps it is just a matter of time before either these strains mutate or acquire new genes for human transmissibility, and then it would really hit the fan. Before that happens, I would like to pass a law that anybody who refused the flu vaccine in the past would not get one moving forward should there be a bird flu pandemic. You gotta have the courage of your convictions, dude. The MMWR has a case of a hantavirus infection in Colorado. The take-home from the case, and no, you don't want to take home hantavirus, is that it occurred in a farm worker. And they point out that roughly a quarter of cases of hantavirus in the United States are in farm workers who are exposed to rodent droppings not only as part of their work, but in the housing that is provided for them. So farming, agricultural work is a risk for hantavirus. I have never seen a case of hantavirus, or if I have, I've missed it, and so was relatively unaware of that particular risk. Relatively, of course, meaning completely. The anti-vaccine wackaloons will sometimes say that there's no such thing as herd immunity. But then the anti-vaccine wackaloons tend to say a lot of things. A while back, there was a study that showed that vaccination of females with HPV led to a decrease in HPV in unvaccinated females. Now, the same thing holds true for men. They found that there was a decrease of 78% in the prevalence of HPV genotypes found in the vaccine amongst men, probably as a result of vaccinating women. So take that, anti-vaccine wackaloons. The Borrelia, the Lyme of Europe, is not the same disease as the Lyme in the United States. For example, they tend to have more Banworth syndrome, which is an acute meningoradiculitis. But having weird neurologic symptoms is part and parcel of neurologic Lyme in Europe, and other neurologic syndromes are not uncommon, as this review showed. It suggested that while cranial nerve palsies were the most frequent, they also were admitted with painful radiculitis, encephalitis, myelitis, and meningitis and headache. And a few unlucky people presented with stroke and delirium. So there are a wide variety of manifestations of European Lyme So when your patients come home from their camping trip in Germany and have a headache or some other odd neurologic symptoms, remember that A, it could be Lyme, and B, the Lyme tests in the United States, at least the standard 2-step, may not pick it up. So really your only choice is to accompany the patient back to Europe and do testing there. At the patient's expense, of course. Puberty is bad. Well, I don't know if this is due to puberty. But this study looked at the prevalence of Fusobacterium necrophorum as a cause of sore throat and found that it essentially was found in people between the ages of 14 and 20, 13.5% of patients, and vanishingly rare, 1.9% in patients under 10. So Fusobacterium predominates as a cause of pharyngitis in the high school and college age groups, where occasionally it goes on to cause pharyngeal abscesses and even Lemierre's disease. The original article on this was in the Annals about a decade or more ago now. Fusobacteria, Fusobacterii, Fusobacterias are interesting bugs, not only causing pharyngitis, but maybe acute appendicitis as well. Belief, it is said, is what you do in the absence of data. But what do you do when you have a lot of curious data, but not definitive data? I, for one, am a big believer, if you want to use that word, in the use of macrolides for messing with all sorts of infections, especially necrotizing infections. With group A strep infections, one should give patients beta-lactam and clindamycin, high-dose clindamycin, in part because of the eagle effect, but in part to mess with virulence factors made by streptococci. But is there data to support messing with virulence factors? Well, in this mouse study published in Clinical Infectious Diseases entitled Clindamycin Affects Group A Streptococcus Virulence Factors and Improves Clinical Outcome, you can guess from the title what it did. Clindamycin improved outcome and it messed with bacterial virulence factors, specifically extracellular DNase SD1 and streptolysin O. Although sub-inhibitory clindamycin levels induced the expression of virulence factors. So if you're going to give clindamycin, and you should, 900 milligrams IV Q8 in addition to your beta-lactam. Screwing with bacterial virulence factors is a good thing, and I am increasingly inclined to do it. Usually you want to give penicillin for syphilis, but sometimes you're stuck giving something like doxycycline. How good is it? This study suggested that, at least in terms of serological response, it is excellent for treating syphilis. 100% with primary, 96.9% with secondary, 91.3% with early latent, and 80% in patients with late latent had an appropriate serological decline, suggesting that it is a good treatment for syphilis. Although I will mention, I recently had a case of a patient who had secondary syphilis and an alleged reaction to penicillin, who was treated with a standard course of doxycycline. He did indeed seroconvert and then developed a uveitis and retinitis for which we could find no explanation. My hypothesis, unproven, is that we eradicated the syphilis everywhere but his eye with the doxycycline. He was placed on penicillin. Of course, he did well, and his eyes got better. True and unrelated? I don't know. I would still just as soon get penicillin for my syphilis. Although I still think my CSF VDRL is a false positive. And that's my story, and I'm sticking with it. And as long as we're on the topic of STDs, there's a report out of Indiana of Neisseria meningitidis, ST11 type, causing urethritis. It suggests that perhaps Neisseria meningitis, especially type 11, may be, as they call it, urethrotropic and be a cause of non-gonococcal urethritis. I still can't figure out how an oral organism gets on the urethra. Two interesting studies out this week in reference to community-acquired pneumonia. One is there is a seasonal variation for community-acquired pneumonia. Legionella, for example, occurs most often in the fall and the summer, whereas strep pneumo, for example, occurs most often in the winter. which doesn't come as too much of a surprise, as Legionella tends to occur during thunder shower season that doesn't occur in January. And strep pneumo and viruses tend to occur when people crowd, and perhaps due to falling vitamin D levels. I don't know about the last. But it would suggest that you don't need to worry about atypical organisms as much in the winter as you do in the summer. Although, of course, giving a macrolide for Legionella also has the added benefit of screwing with bacterial virulence factors like strep pneumo, if you believe in that sort of thing. I don't know anyone who does offhand. But here is the more important study. Infections, as I keep harping on, are associated with vascular events, and it's long been known that an acute pneumonia is associated with an increased risk of a myocardial infarction. That's old news. The new news is that NSAIDs can make this much worse. If you take an oral NSAID during an acute respiratory infection, your risk of an MI goes up 3.4-fold. And if you get the NSAID intravenously, your chance of a myocardial infarction goes up 7.2-fold. So if you have an acute respiratory infection and you're at home, don't take your NSAIDs, unless, of course, you want to die of a heart attack. I have always worried about diabetic foot ulcers, mostly because it serves as an entry for local infection and eventually subsequent limb loss. However, it turns out that people with diabetic foot ulcers are at a marked increased risk for invasive systemic infections, according to this CID article. And if they get these, their mortality rate doubles. Having MRSA and an open ulcer leads to a, quote, high 24-month cumulative probability of invasive infection, 31%, and all-cause mortality rate, 13%. So getting these diabetic foot ulcers to heal up with alacrity is important. Good luck with that. But an open ulcer, especially an open ulcer on a diabetic foot that has MRSA, should be looked at not only as a limb-threatening event, but a life-threatening event. A risk for which I, for one, have never considered before. There was a study reported at a national meeting where obese pregnant women were randomized to either cephalexin and metronidazole post-op orally for 48 hours versus placebo, and the women in the cephalexin metronidazole group had a marked decrease in their surgical infections. Again, this was all in obese patients. What boggles my mind is the surgical infection rates were in the placebo group 16% in all women, 32% in women with ruptured membranes, and 9.2% in women with intact membranes. I would bet a nickel that we don't have infection rates anywhere close to that at our hospital. I always wonder with these kinds of studies how applicable they are to my institutions, and you also don't know from this report how good they were with the basics, things like hand hygiene and skip procedures, etc., etc. So it's hard to know. Generally speaking, antibiotics are usually a surrogate for crappy practice, and if you have a 32% infection rate in your women with ruptured membranes, one has to wonder, even in obese patients, just how good you are at basic infection control and surgical site infection prevention. But there's not enough detail to be able to know until the study actually gets published, since it was a report from a meeting. Oh, and there's a meta-analysis out as to the efficacy of antibiotic-impregnated sutures in preventing infections. They don't work. And they cost more. So probably no need to give antibiotic-impregnated sutures. But if you want to go ahead anyway, I say suit yourself. One of the common causes of consultation is how long to treat a patient with antibiotics. And so often the data is coming out in the last decade that less is no worse than more. This study randomized patients with acute cholecystitis who were having a cholecystectomy to a single slug of cefazolin, 2 grams, versus a single slug of cefazolin followed up by cefuroxime and metronidazole for 3 days. And outcomes, not unsurprisingly, were the same. Once the infected gallbladder is in the pathology lab, it's not causing anybody any problems, and antibiotics really aren't going to do much. It's increasingly clear that as long as the source is controlled or even removed, antibiotics are unneeded. But just try getting people to stop the antibiotics. So often, all I get to hear is,
"Captain, we can't do it."
Yes, you can, Mr. Scott. Trust me. I'm your captain. If you are an infectious disease doctor, you are probably a connoisseur of outbreaks. It's always curious the way outbreaks can occur. And this was an outbreak of E. coli 0157 that was associated with all things pizza dough. Not only is the dough used to make pizza, it was used to make breadsticks and dessert. And patients who consumed these got an E. coli infection. You don't think of, or at least I don't think of, flour as a source of E. coli, but this particular outbreak would suggest that it can be contaminated and serves as a reminder, in my mind, that all food should be thoroughly deep fried before eating. Remember my theory, you die of your subspecialty. So if you're an infectious disease doc out there, you're going to die of an infection. If you are a male obstetrician, you're in a world of hurt. I've always been a fan of the vancomycin taper for C. difficile. I figure it keeps the C. diff at bay while normal flora slowly recuperates from the onslaught of prior antibiotics. In this study, patients with recurrent C. difficile were either given 14 days of vancomycin followed by a fecal enema, ooh, would that be fun, or a 6-week taper of oral vancomycin, and there was no difference in the outcome. Fecal transplants are still somewhat of a pain in something, and it's nice to know that a vancomycin taper over 6 weeks is just as efficacious. Someday, when we have poo pills, I think life will be a lot simpler, as poo pills would make better probiotics than the current products we have. So, the title of the article is, "Do Positive Anaerobic Culture Results Affect Physicians' Clinical Management Decisions?" And they found out that no, it did not. And they suggest that maybe we should not be doing anaerobic culturing. The problem with this study, of course, is that many physicians don't appreciate cultures and respond appropriately. It's amazing how many people continue whatever antibiotic was started when the patient does well, despite the cultures, and how often cultures are not understood by treating physicians. And that's summed up nicely in the following sentences. Quote, "Of the 115 patients whose culture results were reported before discharge, only 31 had their cultures acknowledged by physicians, mostly infectious disease consultants." End quote. I mean, why get cultures at all? So often physicians ignore them. If you want to practice like a surgical resident, sure, don't get cultures. But understanding the patient's disease and their microbiology is part of what makes an ID doctor from a philosophical perspective. Me, I want to know what I'm killing so I know the optimal way to kill it. At the Rutgers Robert Wood Johnson Medical School, they're happy to flail about in ignorance, I guess. And it transitions nicely into an article called ED Management of Patients with Febrile Neutropenia, Guideline Concordant or Overly Aggressive. And they found that the care in the emergency room was discordant with the guidelines 30% of the time, and virtually always in patients at low risk. Confirming, as they said, quote, "Clinicians who manage patients with febrile neutropenia, however, seem to frequently have difficulty conforming their behavior to those recommendations," end of quote. Big surprise, be it neutropenic fevers, the approach to the sore throat, or in all likelihood, the results of anaerobic cultures, people don't know what the hell they're doing. Damn, I'm getting grumpy in my old age. And that, of course, nicely segues into this article that looked at what you can do when your MRSA cultures come back negative. You have a patient comes into the ICU, they get started on probably vanc and cefepime or vancomycin and zosyn, and at 72 hours, all the cultures are negative. Can you stop the vancomycin? You betcha you can. If you don't grow MRSA, as they show in this study, it's not there, and you don't need to treat it. It's not like MRSA or Staph aureus in general is difficult to grow. From personal experience, I would suggest that negative cultures are routinely ignored, and I bet you in the real world, vancomycin would not be stopped. Not only do people not pay attention to positive cultures, they don't pay attention to negative cultures. Meh, 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 meh. Get off my damn lawn, you punk. But if you know what the hell you're doing, you pay attention not only to positive cultures, but you pay attention to negative cultures. Mycobacterium avium intracellulare is, as you probably are aware, two organisms that cannot be distinguished in the clinical lab, and those that have intracellulare in their lung tend to do a little better. M. abscessus, which is a growing problem in the CF population, is also a group of organisms consisting of soon-to-be mispronounced M. abscessus, M. massiliense, and M. bolletii. And there is a clinical difference in the response of patients who have M. abscessus versus M. massiliensis, massiliense. As I said before, we need pronunciation guides sometimes. Patients with M. abscessus, because it was more resistant in part, did worse, and that you could treat the M. massiliense with clarithromycin, which may have made part of the difference in outcomes. They estimate it made about 40% of the difference in the differential outcomes between the two organisms, and suggest that parenteral therapy didn't add much to the care and that it was the oral macrolide that made all the difference. They ain't anaerobes, but it sure would be nice if you had an M. abscessus growing to really know which of the three species it was. I know, get over it. Also in the MAI group is Mycobacterium chimera, Chimaera. And there have been outbreaks of this organism associated with open heart surgeries. It was found in the heater-cooler units used in open heart. The vast majority of cases have been prosthetic valve endocarditis. The minority were in bypass patients, 4%. It does cause the occasional disseminated illness as well. It's a very slow grower, so hold your cultures for a long time if you're looking for it. And there's a nice review of M. chimera infections out of England in this month's Clinical Infectious Diseases with an accompanying editorial. It is a rare but catastrophic infection. And we will finish up with Cryptococcus, a report out of CID of non-HIV patients with cryptococcal meningitis who went on to develop spinal arachnoiditis with lower motor neuron findings such as weakness and gait disturbance and urinary retention. This was a late finding in the disease, a post-infectious radiculopathy that responded to steroids. And, quote, although severe manifestations are often perceived to be due to microbiologic failure, leading clinicians to repeatedly reinstitute amphotericin B induction therapy, we have found clinical deterioration to be mostly associated with negative CSF cultures after treatment at the time of the arachnoiditis diagnosis, end of quote. So a post-infectious arachnoiditis from Cryptococcus occurring late. Great. But at least you have negative cultures to guide you. And that brings us to the end of this relatively petty Puscast, a review of the infectious disease literature covering the last 2 weeks of January in the year 2017. References are available online, edudoc.com, where you can find links to my growing multimedia empire of books, blogs, podcasts, and apps. Because, as you know, the world needs more Mark Crislip. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you, including checking on the cultures. Thank you, in dictation, and goodbye.